Yes,
Hello.
we are live now.
Okay. Hello everyone. Welcome to today's session,
Hello.
Instruments Insight. The White Army is privileged to have Dr. Puneeth PJ, Assistant Professor at JJMMC Davanagere as a mentor today. Welcome to you, sir. Sir is going to conduct an interesting session on instruments used in otorhinolaryngology. Without further ado, we shall begin the session. Over to you, sir. I guess sir is having some network issues. He'll join back. Sorry for the inconvenience.
Hello. Am I audible?
Yes, sir. Yes, sir.
Okay.
Yes.
Okay. Sorry, there was some problem.
Okay,
I'll just
sir.
share PPT 2 minutes.
Yes, sir. Yes.
Okay. Can we
Screen is
start?
visible, sir. Yes, sir. Yes, sir. We
Yeah,
can
yeah.
start.
So welcome everybody. We shall start with ear, nose, and then throat instruments. And we shall start with basic OPD instruments. Then we'll go for OT instruments. Okay. So if there is any doubt, people can ask in between. No problem. We'll start with ear instruments first. Hello. Hello.
Yes, sir, we
Hello,
can
sir.
hear you, sir.
Yes, sir. We can hear you,
I
sir.
don't know. There is some problem. Just a minute.
Okay, sir.
I think I'm not able to share because of some problem.
Okay, sir. So we can share the
Yeah,
screen.
yeah, yeah, yeah.
Okay,
But
sir.
cursor I wanted to use. Let's see.
Oh, okay, sir. Okay, sir.
I'll just try one more time.
Okay, sir.
Yeah, I think now it is visible, right?
Yes, sir. Yes, sir. It is visible, sir.
Okay, okay.
Slideshow mode ke haste, sir.
Yeah, I'm trying. Okay. Yeah,
Yes,
we'll
sir.
start with otology instruments first. So this is one of the most commonly used instruments in otology. That is jobs in our ear probe, right? So this is made up of stainless steel most of the time. It has got two ends. See, this end do not have any hook or anything. It has just only serrations. The other end has got hook, right? So where all do we use it? We use it to remove the wax. We also use it to try to remove the foreign body. We also try to remove the granulation with the same ear probe. But while removing the granulation, we try to use cotton tip. So we put cotton to the serrated end of the Chopsonal probe, and then we'll try to clean it and try to remove the granulation. If there is an ear discharge, we clean it with Jobson ear probe, which is cotton tipped. And probe end is also used to probe polyp. See, we know that there are differences between polyp and turbinate, right? So, in order to differentiate polyp and turbinate, we do probe testing, right? So, this is the probe which we are going to use it. And yeah, we also use it to apply medication. If there is any otitis externa or anything which if we want to apply some ointment, we can use cotton tipped Jobson probe and apply ointment to it, and then you can apply it to ear. Okay, so these are most common use of Jobson probe. And while removing foreign body, we don't just use it in ear, we also use it in nose. Okay, we can try removing the nose foreign body also with this instrument. Okay, this is again another most commonly used OPD instrument in case of otology. Of course, this resembles Tilly oral forceps. I'll show you Tilly just a minute. Yeah, this is Tilly. So if you see carefully, this has got a long handle. I mean long handle, as well as this opening is also quite long, is it not? But whereas this, you have this end which is wide and spade like. So we can, if we are trying to deliver some cotton dressing or something like that, we can use this. Okay, and we also use it to remove foreign bodies in the ear. Okay, so this is Artman's oral forceps. This is one of the most widely used forceps in otology OPDs. Another is this Tilly oral forceps. Okay, although this is oral forceps, we also use it in nose. Okay, although it is designed for otology, we also use it for nasal part also. Again, this is an angled instrument with serrations, and we use it to pack or unpack ear canal as well as mastoid cavity as well as nose, to pack and unpack nose in case of epistaxis, or if you want to pack the nose with medicated wicks, again we can use this. Okay, we can also use it to put medicated platelets for local anesthesia in nasal cavity. While we do DNE, prerequisite for DNE is local anesthesia, right? So we can take cotton platelets, soak it in 4% lignocaine with adrenaline, then you can use this to put the medicated platelets into the nasal cavity. Again, you can use the same instrument to remove the medicated platelets as well as to remove the nasal cavity. We can use it. Okay, remove the foreign bodies in the nasal cavity, crust, debris. We can use this instrument. So this is the Tilly's oral forceps. Again, although the name is oral, we also use it for nasal cavity. Again, this is one of the most commonly used instrument in otology. That is Lucas curved oral forceps. Advantage of this is we hold the forceps at this level. We use thumb and index finger to hold it, and because of this angulation, it will not, the handle will not come in your view. So you can easily place medicated wig or remove the foreign body or wax whatever you want with ease. Next, another important instrument which every UG should know is tuning fork. There are two types of tuning fork, which is Hartmann and Gardner tuning forks. Tuning fork has got different parts. What are those parts? They have got two prongs, they have shoulder, and they have stem and base. Okay, always hold the tuning fork at the stem. Don't hold it near the shoulder or never touch the prong. Prong is to I mean, you have to put it under vibration after tapping on the thinner and hypothinner eminence, right? So if you hold the prong, again it will not set it into vibration. So always hold the tuning fork in the stem. So we generally in otology we use three different forks, tuning forks, which are those 256, 512 and 1024. 128 we hardly use it. For neurological examination we use 128, but for otology we use 256, 512 and 1024. And amongst all these three, the most commonly used for tuning fork is 512. So why do we use 512? Actually, I have already told this in otology class. Just to finish up, we use 512 because it falls in mid speech frequency. Our speech frequency is 20 to 2000, right? So 512 happens to fall exactly at the midway. So patient can hear it, and patient can understand it, and patient can interpret it better. That's why we use 512. And overtones are very minimal. Overtones means to say, if somebody taps the tuning fork little harder, it may produce frequency which is of not native to the tuning fork which we use. But with 512 it do not happen. It will always produce a sound which is of 512 hertz only. And another important reason is tone decay. Tone decay. What is tone decay? If you put any tuning fork to vibration, it has to vibrate for a prolonged period so that it produces sound waves for a prolonged period so that you can examine easily. For example, 256, the duration of production of sound is very minimal. So it is difficult to assess hearing. So with 512, that is not the case. This whole scenario, what I explained, is known as tone decay. So tone decay is very good. I mean, it's very minimal in case of 512. So you can easily test with the patient. Another not so important reason is sound is more audible than tactile. So 128 is we use it for tactile sensation, but for auditory we always use 512. Okay. And why do we, what are the tests which we do it for, which we do using tuning for test? Most commonly done are Rinne, Weber, and absolute bone conduction test. Why do, I mean, on doing all these tests, what interpretation do you get? You get to know what is the type of hearing loss, and also if you use all three tuning fork in Rinne, you will also get to know the extent of hearing loss or the magnitude of hearing loss. So quantity and quality you will get to know by tuning fork test. Okay. Okay, this is the tuning fork. And again, I don't think you people would have seen much of this instrument. This is known as Siegel's pneumatic speculum. Why pneumatic? Because we use air. Why? And see, it has got different parts. It has got bulb, which is made up of rubber. It has got rubber tube, it has got oral speculum, and it has got eyepiece. Okay, and if you see carefully, this lens, which is the convex lens what we use, it is not straight, it is not placed in a straight angle, it is placed at an angle. So why do we place it at an angle? If this angulation should be in parallel with that of tympanic membrane, then only you can see tympanic membrane in a better way. Okay, and it usually gives magnification up to 2.5 times. Okay, and where all do we use it? So one, to see for movement of the tympanic membrane, what we do is we select the appropriate size speculum, ear speculum. See, this may be big for some patient, small, it may be small for some patient. So select appropriate size speculum. It should snugly fit the ESC. It should not tightly fit, or it should not. I mean, it should not be like very loose. It should snugly fit the ear external aortic canal. Then you put the what is that eyepiece into the speculum and you visualize it. Then, if you press this, there will be pressure change through the speculum and in the external aortic canal. Because of the pressure changes, tympanic membrane move. So tympanic membrane should move in all the cases. If there is failure of movement, then there should be otitis media with effusion or any pathologist for that matter. So that whole whatever I told so far is known as cecalization. Okay, cecalization is a normal feature of any tympanic membrane. Okay, what is fistula test? So this also I have explained in otology case presentation. On pressing the tragus intermittently, patient should not have giddiness and nystagmus. This is fistula negative. This is normal in all individuals. If there is fistula between the inner ear and middle ear, that is following cholesteatoma which has eroded the lateral semicircular canal, or following surgery, on intermittently pressing the tragus, you will get nystagmus and giddiness. This is known as fistula test being positive. There is another way where you can do fistula test, that is by Siegel speculum. So you put Siegel speculum and you just change the pressure in the bulb just by pressing it, and there will be pressure change in the external aortic canal, and the same pressure will transfer into middle ear. If there is fistula, patient will develop giddiness and then nystagmus. Okay. Again, as I told, it gives 2.5 times magnification. You can use it to examine the tympanic membrane. Okay, and also you can use it to instill medicines into the middle ear. What you can do is just put few drops into the external aortic canal, put the Siegel speculum. You just change the pressure in the bulb. So because of the pressure change, the drops will eventually go into the middle ear if you want it to use it. Okay, although we use it less nowadays, but we still use it in some of the cases. Okay, this is Siegel's pneumatic speculum. Yeah, this is another instrument which we use it very rarely nowadays. I don't think you people would have seen it. So this is eustachian tube catheter. If you see carefully, there is a bend, right? And there is a hook at the beginning of this eustachian tube catheter. So this shows to which direction this bend is present. So initially what we used to do, especially Politzer is the one who used to do this eustachian tube catheterization and all. What they would do is they would pass the eustachian tube catheter into the nasal cavity along the floor, then turn it. If they have to, I mean, on turning, you will get to know which side this angulation is present by looking into the ring. I mean, the direction of the ring. If you want to instill the eustachian tube, you just go there and then you can instill the medications, or you can just instill air to make sure the middle ear is aerated, all those things. But nowadays we don't use it because we understood that this instrument is not so good for a eustachian tube catheterization, and also we understood that it caused more injury. So we don't use it nowadays. We use it nowadays to remove the foreign body in the nose. That is one of the common uses nowadays. But still you should know eustachian tube catheter. Okay, this I have already explained anyway. Okay, this is otoscope. This everybody has seen, I guess. Hello? Yeah. So this before you used to use pneumatic Siegel speculum to have a magnified view, right? But with the introduction of these, you can easily see the corners of the tympanic membrane. You can visualize the attic region, all those things. So in the head of this otoscope, there will be battery. I mean, so battery will be in this part, in the handle part, but in the head part there will be bulb which is housed. So you can see through this, and you can insert this disposable ear speculum into the external aortic canal, and you can examine the tympanic membrane, and if there is any perforation, you can also examine the middle ear. And if you see carefully, there is a small opening here, right? So this will aid in attaching Siegel speculum. So we can attach that seagull, pneumatic seagull speculum to directly to otoscope, and you can do seagulization directly through otoscope. This we actually do it. Most of us we use otoscope rather than seagull speculum nowadays. And some books gives magnification of 2 times, but it is not so. It will give magnification of 8 diopter, which is around 3 times. Okay, so this is important. Again, there are so many companies which comes with the otoscopes. Wherein is one of the standard ones. This you should have seen it. Simpson oral syringe. I'll just go. Yeah, this is Simpson oral syringe. So where all do we use it? We use it for syringing purpose. So most of the time you use it to remove the wax, but we also use to remove foreign bodies in the external aortic canal, more so non-hygroscopic ones. Okay, what do you mean by hygroscopic or non-hygroscopic? For example, if a child has put some seed into the external aortic canal, if you try to do syringing, as the seed absorbs water, it swells up, right? So it is better not to use syringing for hygroscopic materials like seeds. But if it is small, it will definitely come out. If it is big, it is contraindication. Okay, Simpson oral syringing is contraindicated in bigger hygroscopic foreign bodies. Bigger hygroscopic foreign bodies. So what are the contraindication? Common sense is any perforated drum is a contraindication. Why? Because you are introducing some water or foreign body, right? Again, patient will go for AOM, ASOM, or exacerbated CSOM, or even it may cause caloric effect to inner ear leading to giddiness. Okay, and if there is any painful otorrhea, again you should not do it. Give antibiotics, painkiller, then you re-examine the next day, then you can do it. So otitis externa, CSF otorrhea, these are all a major contraindication. Again, if you are suspecting very thinned out tympanic membrane, again you should not do syringing because it may cause perforation of eardrum. So what are the complication of this syringing procedure? Most common is tympanic membrane perforation. If you use it with force, again it will cause perforation. And what should be the direction? You have to direct this end to the posterior superior part of the external canal, so that when you push the water in, it goes and pushes the wax outside. Outside of the ear canal. So it should be the direction should be in the posterior superior direction or posterior superior quadrant direction. Okay. And what are the complications? One is perforation of eardrum. Second is caloric effect, and third one is again ASOM, CSOM. Yeah, these are again most commonly used OPD instruments. These are oral speculum. These are made up of stainless steel most of the time, or you get plastics disposable ones. But disadvantage of stainless steel is that if you use it and try to examine the tympanic membrane, what happens? The light will reflect from these walls, right? So you may not be able to examine properly. That's why recent oral speculum, they are all plastic ones, or even if they are stainless steel, it will be colored ones. Okay, there are different ones. There are Hartmann's, Shea speculum, Rosen speculum, like that. The thing is, these just a minute, yeah. This opening will aid you in injecting the local anesthesia when you are trying to do tympanoplasty or myringoplasty or stapes surgery. Any ear case under LA, you can use this to inject the local anesthesia. These sedations will aid. Again, this will also aid in injecting. Okay, where all do we use it? One, for OPD examination of the external canal, tympanic membrane, like that. And again, while removing the foreign body's wax, we can try to use it. And while injecting local anesthesia, or while doing surgery itself, which is myringoplasty, myringotomy, stapes surgery, we can use this speculum. But disadvantage of this speculum is you have to hold this in one hand. But this Holmgren self-retaining oral one, you can just put it, and this screw will hold it in position. So you have both hands which are free, which you can use it to operate. Okay, these you have to hold it in one hand, whereas this one, Holmgren self-retaining one, you don't have to hold it. You can use both hands for operative purpose. Okay. Okay. So now coming to moving slowly to operative procedures in otology. One of the most commonly done operative procedure in otology is myringotomy. What is myringotomy? It is otomy is opening. Laparotomy is opening abdomen. So any otomy is opening. So here what are we opening? We are cutting open the tympanic membrane. So it is a surgical procedure wherein we open, we make a surgical incision on the tympanic membrane. Okay. So the name of this myringotomy is polyps or myringotomy. So where all do we do myringotomy? Most common example is unresolved otitis media with effusion. And other most common indications are ASOM, which is not responding to medical line of treatment. Okay, these two are the most common indications for myringotomy. So, what is the name? Polyps or myringotomy. If you see carefully, just a minute, see you have diamond tip which will aid in puncturing the tympanic membrane. So where else, where do you do incision? Where do you make an incision on the tympanic membrane? You put an incision in the anterior inferior quadrant. Why in the anterior inferior quadrant? Why not in the posterior quadrant or posterior superior quadrant? There are too many important structures in the posterior quadrant. Which are those? There is incudostapedial joint, there is what is that, facial nerve which may be hanging down because of the discent fallopian canal, and even there is sorry, so so there is oval window as well. So you avoid this area because you may end up injuring them. So we always make incision in the anterior inferior quadrant. But sometimes the discharge will be very thick. It may not come out just by making an incision. There, what we do something known as Bierkan principle. What is Bierkan principle? You make one more incision in the superior quadrant. Okay, that while making so, you have to be a little careful. Preferably, we do it in posterior superior quadrant. Again, you should be careful because there are important structure. What happens here is that by gravity, discharge will collect in the inferior quadrant, right? Now you have made an incision in the superior quadrant. Now air will enter through the incision and pushes the thick fluid which is there in the middle ear through the incision which is down below. So this is known as Bierkan principle. Okay. So just like you open a pint of beer, it acts like that. So by pressing, air will enter and the other part will open up, right? Just like that, this will also act. That is known as Bierkan principle. Okay, now coming to grommet. So you do myringotomy, then most of the time we don't stop it there. We have to insert grommets. What are these grommets? These are small ventilating tubes which are placed across the tympanic membrane. Okay, where do we use it? We do it in most of the time we use it in otitis media with effusion, and lesser known indications are if we want to put drugs to the middle ear through an incision. If you put incision, it will close up. So rather we put grommet and you can instill the medication into the middle ear through this grommet. We use it for sudden onset sensorineural hearing loss and also in media. These are lesser known indications, but these are indications. Most common indication for grommet insertion is otitis media with effusion. So what is okay? What is the treatment for otitis media with effusion? Just to complete, you have to do adenoidectomy, you have to do myringotomy, then you have to insert grommet. That is the complete treatment. Adenoidectomy, myringotomy with grommet insertion. Okay. Okay. Which materials do we use? I'll just show these grommets. So grommets look like this, something like this. These are some of the designs of grommets. We use whatever is available, we can use it. There is T-shape, there is Shia one. So there are too many types. There are Donaldson's one. So whatever is available, whatever is good for patient, we try to use it. So these are made up of stainless steel, plastipore, fluoroplastic. even titanium, all those things. Silicon is the most preferred grommet material because of its less reactive property. Okay, and what are the sequelae of grommet insertion? Sequelae means to say after inserting grommet, what happens to grommet? Most of the time, it excludes out itself. So what it is material effusion, there will be thick secretion. So just by sucking out, it will not come out. You input grommet so that it aerates the middle ear, right? So maybe after 2 to 3 months, it will extrude out. Then the perforation may heal by forming tympanosclerotic patch, or it may heal by fibrosis. Sometimes it will not extrude out. It will stay there for 6 months or 1 year. If that is the case, we have to remove it surgically. Sometimes the grommet may displace into the middle ear. Again, we may have to make an incision. We have to elevate the tympanomeatal flap, take out the grommet. Sometimes grommet will extrude out, but the squamous epithelium, which is present in the outer layer of the tympanic membrane, will move into the middle ear, leading to secondary acquired cholestoma. Or the grommet will extrude out, nothing will happen, perforation remains there. It may lead to ASOM, CSOM. That again we may have to close it surgically in the later date. Okay, I hope I have cleared that doubt. Okay, this is one of the instrument. See, the thing is, we don't get this in grommet introducer all the time. We use whatever is available. We can use something known as cuff forceps. There are something known as alligator forceps. Again, I will show you. So this is one of the rarely used instrument. If it is available, you can use it. So you hold the grommet with the mouth of grommet introducer, and then you put it. Okay, so it will not be available in all the time. We also call it as grommet plunger. Okay, so just for completion sake, I have put it. Okay, now coming to tympanoplasty, one of the most commonly used and versatile instrument in otology is this Mollison's self-retaining post-oral mastoid hemostatic retractor. Okay, so if you tell the complete name, examiner will be very happy. Why? I will tell you. Why do we name it as? Why it has got such a long name? Mollison is the one who has popularized and designed this instrument. So this is Mollison instrument. In which anatomical area do we use it? Post-auricular area. Where exactly in the post-auricular area? In the mastoid region. See, there are four teeth, right? Four teeth on either side. These teeth will hold the tissue, and if there is any minimal bleed, it will also cause hemostasis because of the pressure effect. So hemostatic. It has got a lock. So it is a self-retaining, right? So what is the complete name? Mollison's post-oral mastoid hemostatic self-retaining retractor. That is the complete name. Please make a note of it. Just by looking into this instrument, you can kind of get to know. Sorry, you can tell. So Mollison's post-oral self-retaining hemostatic mastoid retractor. Right? I hope you got this point. So where all do we use this? One, see, tympanoplasty can be done endorally or post-orally, right? If you are doing post-auricularly, we put an incision, that is William White's incision. Then you have to hold the tissue, right, to harvest the tissue. That time we use it to put the tissues apart, and you can harvest the graft. You can do as well as you can do tympanoplasty with this. On retracting this tissue, you can as well do mastoidectomy. And as I told, it is one of the versatile instrument. We also use it. Some surgeon use it while doing tracheostomy, laryngophageal surgery. And to my surprise, one of the neurosurgeon also used it to do spine surgery. So this is one of the versatile instrument. You can use it. If you tell complete name again, examiner will be very happy. So this is Mollison's. There is one more instrument, that is Plester mastoid retractor. What is the difference between Plester and Mollison's? It has got only 2 prongs, whereas Mollison had 4 prongs, whereas Plester had 2 prongs. That is the only difference. So if you want to hold too much of tissue, we use Mollison's. If you want only slight tissue retraction, then we use Plester. I hope you got my point. Okay, but if you are a otologist, almost always you will have at least one Mollison. Okay, Mollison is one of the most preferred. Another is Lempert's endoral speculum. See here, we can hold with hand, and this will open up. By opening up, you can instill infiltrate. I mean, you can infiltrate the local anesthesia easily. This is again one of the most commonly used instrument for in otological surgery. Lempert's endoral speculum. Okay, we also use it to put an incision, but most commonly we also, I mean, most common uses while infiltrating local anesthesia into the external aortic canal. Okay, now, so these are few of the cutting burrs which we use it to do mastoidectomy. See, there are so many types of burr. This is conical burr. All these are conical burrs only, but this is round burr. Okay. So again, these burrs we use it to do mastoidectomy. Bigger the burr, it will take out most of the bone. So to begin the mastoidectomy, we use bigger burrs. After defining the boundaries, we try to use smaller burrs. Okay. Again, there are so many elevations and depressions. Depressions are depressions are known as sites. So if there are few sites, it will take out more tissue again. And we don't use tip to drill. We don't use this tip. Rather, we use side part of the burrs to drill the mastoid. So you always use the side part of the drill, not the tip part. Okay. And these are made up of stainless steel, titanium, carbide. You can use, I mean, so many things we can use it. But this titanium is a very good material for this, and it will last longer. Steel in one or two surgery it will kind of give away, but titanium is very good for mastoid burrs. And again, it will vary in size and length depending upon the surgeon's need. We use it of different sizes and lengths. Okay, there is something on a see. All these serrations, sorry, all these serrations will take out the bone, right? Sometimes we may have to smoothen the bone. If you just leave too much of mastoid bone and chips, again it may kind of lead to granulation formation post-operatively. We have to smoothen the bone. So for that we use something known as diamond burr. Here, these serrations, what you see, sorry, these serrations what you see will not be there. It will be smooth surface. So I didn't have that photo. The burrs will look the same, but the serrations will not be there. That is known as diamond burr. We use it to smoothen the cavity, and we use it whenever we are near the facial nerve. Why near the facial nerve? Because if you operate elsewhere, if you use the same drill burr, that conical and those round burrs on near the facial nerve, it may injure the facial nerve, right? So in order to avoid injuring the facial nerve, whenever we are near the facial nerve, we switch over to diamond burr. Okay. Okay. Now coming to tympanoplasty instruments. Again, all these can be used in tympanoplasty. Now coming to micro ear surgical instruments, I mean. So this is one of the next 2-3 instruments what I tell, these are versatile instruments. So some surgeon use only one instrument for all the purpose. Some surgeon use one instrument for one particular use. So it depends on the surgeon, but you should know all the instruments. So this is McEwan cell seeker and curette. So if you see carefully, there is a bent end which is slender, and it has got an angulation. The other end has got a curette. If you want to curette at the granulation, if you want to curette at the bony hang while doing mastoidectomy, use this end. And while doing mastoidectomy, you have to enter the mastoid antrum, right? So you can use this to see if there is any, if we are entering into mastoid antrum, or are we near the important structure, we can see. Okay. And some surgeon also use this for pressuring margins, but it is very rare. Almost all the time, these two are important functions. Okay. Again, ball probe. Where all do we use ball probe? This is sheath ball probe. Again, while doing mastoidectomy, there are too many important structure in the middle ear as well as near the mastoid, right? Posterior limit is dural, I mean, sorry, sinus slit. superior limit is sine dural plate. So you should not injure them, right? Again, there are middle ear structures which are very, very important, ossicles, facial, or all those things. So you should not injure. While doing mastoidectomy, just to see if I'm in the right direction or if I'm not near the important structures, we can use this to palpate those structures. And also, while positioning graft, we can use it to adjust the graft while doing tympanoplasty. So this is ball probe, which is she's ball probe. Yeah. So this is curved pick. Most there are two types of curved picks. Most commonly used is cavitron. So I put only cavitron here. See, it has got a sharp end which is curved. This instrument, we use it for so many purposes. We use it to remove the tympanoclerotic patch. We use it to freshen the margin. We use it to put an canal incision. We use it to spread the graft, and we use it for stepidotomy, Myringotomy. We can use it for so many purposes. That's why next 2-3 instruments, these are all versatile instruments. Depending upon the surgeon's wish or surgeon's comfort, he chooses the instrument. So this is elevator. See, we put canal incision, right? After putting canal incision, we have to elevate the skin of the external artery canal bone. So we use this flap elevator. We call them as flap elevator. And Paparella is the one who has used this instrument to the maximum extent. Hence the name Paparella flap elevator. Again, this instrument, it has see, this end is blunt, right? So you can slowly kind of elevate the flap. If there is any granulation, you can slowly remove it. If there is any cholesteatoma sac, you can try to dissect it from the adjacent important structure. Okay, and you can also try to uncover the bone over the facial nerve while doing facial nerve decompression. Okay, so I had shown you that straight pick, right? This is an angled pick. So see, there is an angulation. Again, the indications are same. Okay, it depends on surgeon preference. If you want to use curved pick, you will use it. If you want to use straight pick, you will use it. Okay, and if there are some difficult areas to access with the straight pick, we change over to angled pick. That's all. Yeah, this is one of the versatile instrument. This is one of the most commonly used instrument, and I use it almost for everything. So this is micro ear sickle knife, which is Shia. If you don't know, Shia name is also fine, but you should know sickle knife. See, if you see carefully, it looks like a sickle, right? Hence the name sickle. The indications where we use these instruments are plenty. You can do myringotomy with this instrument. You can do grommet. You can insert grommet with this instrument. You can do you can freshen the margin. You can elevate the flap. You can put the skin incision on the external canal. You can use it. You can spread the graft. You can use it for everything. But it depends on surgeon preference. Remember, this is sickle knife. If you tell at least sickle knife, it's fine. And we also use it in case of FES surgery, but their handle will be quite long. For uncinectomy, some of the surgeons use sickle, where handle will be quite long, but still, I also use it. Same here, sickle knife, I use it for nose while doing uncinectomy also. So uses are plenty. It depends on surgeon's choice. Yeah, another is straight pick, that Cavitron straight pick. Same indications, nothing else. Yeah, this is flag knife. If you see carefully, the end, it looks like a flag, is it not? Hence the name flag. So where do we use it? Canal incision you can put with all the instrument, but at 6 o'clock and 12 o'clock, it is difficult to put with regular instrument. So for that, we use this flag knife. And also, if we are elevating 6 o'clock or 12 o'clock skin of the external canal from the bone, again you can use this. Again, you can use it for all surgeries, myringoplasty, tympanoplasty, or cycloplasties. Yeah. So difference between this and this instrument is, see, this end is kind of, it has got a resemblance of flag, right? Whereas this is a round knife which is bent at an angle which is around 120 degree. So this we use it to put an incision on the external canal while elevating the tympanomeatal flap. We can also use it for myringoplasty, tympanoplasty, and freshening the margin, especially under surface of the remnant tympanic membrane. We can use it. We can use it for all purposes. So this is round knife. This is round knife. This is flag, and this is sickle. These three are very, very important. This is sickle, this is flag, and this is round knife. So uses are almost same, depends on surgeon's preference. Yeah, this is alligator. So there are two alligator forceps in otology. One is micro alligator forceps. Why do we call it as alligator? See, this will not open up. Only the mouth of the forceps will open up. So it looks like a mouth of alligator, right? So we call it as alligator forceps. And some of the authors also say it as crocodile forceps. It doesn't matter. You can use alligator as well as crocodile. So advantage of this instrument is that you can hold the what is the temporalis fascia graft. You can easily deliver the temporalis fascia graft into the middle ear for proper placement. You can also use this to use cotton platelets, which is soaked in adrenaline, to deliver it into middle ear. So and you can also use it. I told in grommets, right? So we do not have grommet plunger actually. What we do is we hold the grommet with this alligator forceps and then we deliver it to incised site. So whatever you want to deliver into middle ear, you can use it. So where else is the alligator forceps present? It is present in if you want to retrieve the foreign body of the esophagus or the bronchial foreign bodies, that those alligator forceps are long. But this is micro ear, which is this is also alligator because mouth also looks like that, but it is micro alligator forceps. That is alligator forceps to retrieve the foreign body of esophagus and trachea. Okay. Okay. Now that ends specimens. I mean instruments of otology. Now we'll quickly move on to instruments of nose. So this everybody should have seen it. What is this? Tadicum. This is how you should hold the tadicum. Right. This is how you should hold it. So your thumb should come here, index finger should come here, and these two fingers, your middle finger should come to this side, and your forefinger should come here to close and open the tadicum. So you close it, then you introduce into nasal cavity, then you release it. Okay. So you hold with thumb and index finger. Your middle finger should come here, and your forefinger should come here, and use the middle finger and the forefinger to close the handle of the tadicum, introduce it to nasal cavity, then you release it. Okay. So where all do we use it? Routine nose examination, that is for anterior rhinoscopy, to examine the nasal septum, lateral nasal wall, or whatever you see it in anterior rhinoscopy, you use it. Therapeutic purpose, if there is any foreign body, you can try to remove it. While giving enteral wash also you can use it. While packing the nose, you can use it. Okay. So this is one of the most commonly used OPD instrument. Okay. Next, what is the difference between this Tadicum and St. Clair Thompson nasal speculum? Tadicum blades are very small. See the length of this handle. I mean length of the blade. These are small, is it not? Whereas here the length of the blades are longer. So St. Clair Thompson is the one who used this speculum. Where do we use it? We use it mostly for operative purpose. If you want to take some biopsy, which is there in the anterior part of the nasal cavity, or while doing septoplasty, SM, or polypectomy, you use this. This is mostly for OPD purpose. This is for operative purpose. What is the difference? Length of the blade. Okay. Now, what is this? This is Killian's nasal speculum. This Killian's nasal speculum, it can be short, it may have short blade or the longer blade. It has got different sizes actually. There are 3 to 4 sizes. You use it according to which patient we are operating. In pediatric, Killians are also available. What is the advantage? There is a screw mechanism here, right? So you press these to handle, this Killian speculum will open up, and you tighten the screw, it will retain itself. So what is the advantage? It retains itself because of this screw, and you can easily operate. You can use both hands for operative purpose. Whereas this Centler, Thompson and Tadicum, one hand will be using the speculum, other hand will be operating. Whereas this, if you can use this screw, you can just leave it behind, it will hold in its position. You can use both hands for operative purpose. Okay, again, you can use it for all the diagnostic as well as surgical procedure. Most common use of Killian's nasal speculum is septoplasty SMR surgery. At least you should tell septoplasty SMR surgery, but we use it for all surgical procedure. Okay, for all surgical procedure we can use it. While for removing foreign body, for giving antral wash, for polypectomy, for taking biopsy, you can use it for everything. The biggest advantage is it will retain on its own. Okay, yeah. So this is Killian's nasal speculum. This is St. Clair Thompson nasal speculum. What is this? St. Clair Thompson posterior rhinoscopy mirror. So how many St. Clair Thompson we have come across so far? Two St. Clair Thompson. One is nasal speculum, another is posterior rhinoscopy mirror. So how to sight is posterior rhinoscopy mirror, not ideal mirror. This angulation is there, right? So it is a bayonet shaped. It has got bayonet shaped angle. Why this angle should be present? Because while introducing, if the angle were to be straight, if the handle were to be straight, light will not go properly. You will not, it will obstruct your vision. So it will come in your way of weaving. So if you have this angulation, it will not come in your way of weaving. You can easily do posterior endoscopy. Okay. So again, remember, it is a plane mirror. It is neither convex nor concave. It is plane mirror. It comes in different sizes. Smaller the mirror, better in posterior endoscopy. Bigger the mirror, better in ideal. Remember, bigger mirror for ideal, and then smaller mirror for posterior endoscopy. So ideal mirror handle will be straight, whereas posterior endoscopy mirror will have this bayonet shape. Okay. So continuing with septoplasty instrument, we use Tadicum, we can use St. Clair Thompson, we can use Killian's. After infiltration, you will put an incision. Then you have to elevate the mucoperichondrium and mucoperiosteum, right? So we use this Freer's elevator. Okay. So it has got two ends, right? We can use either end. Sometimes this end will be broader, this end will be narrower. Depending upon where you are elevating, what you are comfortable with, you choose the end. That's all. So where to use? Most of the time, first and foremost use you should tell to elevate the mucoperichondrial and periosteal flap in case of septoplasty and SMR. That is the first one. Other indications are you can displace the inferior turbinate laterally. You can use it for you can use it to medialize the middle turbinate. You can medialize the middle turbinate while doing FES. You can use it to lateralize the inferior turbinate. You can use it for uncinectomy purpose. You can use it for everything. And one of the biggest advantage of this instrument is we also use it in case of ear surgery. While taking graft, we need to tease it. Okay. So while teasing, we use this instrument for teasing purpose, teasing the temporalis fasciae graft. And also while elevating the muzzle and the pedicle on the mastoid, there is mastoid gouge. Definitely we use it. That is Lempert's gouge. Sorry, I forgot to add that instrument. But for regular tympanoplasty, you don't have to use that. You can use this simple Freer's double-ended mucoperichondrial elevator. So if you just tell Freer's elevator, it's fine. Okay. Okay. So you have elevated. Oh, you have not added a lab. You have elevated. Then you use this lux forceps. So where do we use this lux forceps? You engage the dislocated bone, which is septal bone, with this lux forceps, and you twist it and then remove it. Okay. So lux forceps is used to remove the deviated part of the septum after elevating the mucoperichondrial and mucoperichondrial and periosteal flap. Okay, so lux forceps is used to remove the deviated part. So you engage the dissected part of the septum with this, and you twist it so that whatever the tissue you want it is removed. We also use this lux forceps for biopsy purpose. If you want to take biopsy from nasal cavity, if there is any mass, we can use this lux forceps. But most common use of lux forceps is septoplasty and SMR. Okay. Then after removing, there will be spur, right? So there will be spur. How are we going to remove the spur? You cannot use lux forceps to remove the spur. Rather, use this nasal gauge. What is the name of the nasal gauge? Tillis nasal gauge. What we do is, see, there is a V-shaped tip, right? So we engage the maxillary crest with this instrument, and then with this heat, we with wrist movement, we kind of hammer it. So we'll hammer it, and then slowly we kind of take the crust out of its position. So this is nasal gauge or gauge we call. Sorry. Yeah, this is nasal gauge, which is still is, and this is heat. It looks like a hammer, right? Okay. So we use it to remove the maxillary crust. Then this I have already told. Now, so septoplasty instruments are over. Now coming to endoscopes. So these are your nasal endoscopes. These are rigid nasal endoscopes. There are no flexible nasal endoscopes. There are only rigid nasal endoscopes. It comes in different sizes. 4 millimeter diameter, we use it for adults. 4 millimeter diameter. And for pediatric age group, we use it for 2.7 millimeter. Okay. And if you see, there are colors, right? Green, red, like that, right? And if you see, it has got kind of beveled end. So these are all angulated scopes. These two are angulated scope, but there is no beveling here. This is 0-degree scopes. So scopes are available in 0 degree, 30 degree, 45 degree, 70 degree, 90 degree, 120 degree, like that. But for easy purpose, so that sister can easily give you the instrument whatever we need, we have color coded it. So 0 degree for green, red for 30 degree, black for 45, yellow for 70 degree. Okay, so we have done color coding just for easy recognition. Okay, so for adult we use 4 millimeter endoscopes. For pediatric we use 2.7 millimeter endoscopes. And for regular FES we use the 0 degree. And if you want to operate frontal, then we use angled endoscopes. Okay. So these are some of the suctions which we use it. So there are straight section which you would have seen it in case of septoplasty and SMR, but in FES we need curved section which are more important. So Killian is the one who has designed these suctions. So we have named after them. Killian's curved nasal suction tip. Okay. So where do we use it? While doing FES, if there is any discharge in the maxillary sinus, in order to suck it out, or if there is any fungal debris to suck it out, we use this. We use this Killian's curved specula or curved suction tip, and we also use it for frontal recess. You cannot give wash with straight, nasal suction, right? So we prefer curved even for frontal recess. Again, these can be made up of stainless steel, depending upon the material what they use. But most of the time, it will be used. Stainless steel will be used. The other end, the opposite side of this will have a small opening that will act as a kind of guard. You can close it and the suction pressure will increase. You open it, suction pressure will decrease. So depending upon where you are operating, what you want to do, you can use the small opening. Unfortunately, that is not there in this, but there will be small opening on the opposite side. Okay. Yeah, this is ballpoint probe. So ballpoint probe, there are two we discussed so far. One is for ear, another is for nose. Ballpoint probe for ear will be shorter, okay, and slender. Even for nose, it will be almost same, but it will be slightly lengthier. So most commonly we use it to locate where exactly the maxillary sinus ostium is. Where are the sphenoid sinus ostium? We use it. And with ballpoint probe, we also do uncinectomy. Okay, so this is one of the like it is kind of guide. If you want to see what is the consistency of the mass, or if you want to know where we are, we kind of directly go to this ballpoint probe and we try to navigate ourselves. So this is act as a navigator actually. Most of the surgeon use it as a navigator, but most commonly we use it to locate the maxillary sinus ostium, to do uncinectomy, to medialize the middle turbinate, and to also see for the consistency of the mass. Okay. Again, if there is any polyp, we have to catch and take it out, right? So most commonly used instrument is Blackesley through cut forceps. What is this through cut? If you see carefully, there is a opening here. It is not complete, right? So this upper part will come and engage in this opening. So what it does is it cuts through the tissue, hence the name through cut. So Blackesley is the one who has designed this, hence the name Blackesley. And if there is no opening here, and if it were to be of same size, we could have just told it as straight forceps. As it cuts through the tissue, we call it as through cut forceps. This is to hold the tissue, take the biopsy, take the polyp out, we use this. Okay. Advantage is it will bite what we want to bite. It will not tear up. If there is no through cutting mechanism, we can hold the tissue, but while removing the normal mucosa surrounding normal mucosa will also strip off. In order to avoid it, he has designed this instrument. Yeah. So these are some of the cup forceps. See, the difference between through cut, there is an opening here. Just a minute, sorry. There is an opening here, right? But here there is no opening, right? So it catches the tissue, then you have to kind of have a rotating movement, then you pull it. If you are sure it is just a polyp, you don't want, if you are sure that you are not injuring the adjacent structure, you can just take this instrument and grab the tissue and pull it out. But if you want important structures, if you are operating near the important structure, if you want to retain the normal mucosa, we use through cut. That is the only difference. It comes in different angle actually. It comes in 0°, 30°, 45°, 90°, like that. So if you are operating near the frontal, we take 45 to 90°. If you are operating straight ahead, we use 0°, like that. So this is also Blackesley, but it is a cup forceps. So this is straight cup forceps. Just a minute. This is straight forceps. These are all angled forceps. That's all. We use it in case of FES. Yeah. So now the first step in FES is uncinectomy, right? With ball probe, you have identified the uncinate. So you take this backbiter. See, if you kind of approximate these two handle, this will close. So you engage the tissue in this and you close this, it will bite. So it bite backwards. It won't bite forwards, right? Hence the name backbiter. Okay. So we use it for uncinectomy purpose. So this is a backbiter. Okay. So I hope you got my point. Okay. Again, this is through cut, which is designed by Grunwald. You don't have to worry about which is Grunwald, which is Blackesley and all. Just remember, if there is any opening, just a minute. If there is any small opening, okay, like this, it will be through cut forceps. If there are no opening, it will be just cup forceps. That's all. Yeah. So whatever instrument I showed so far, it is to hold the soft tissue. Bones cannot be cut with that. But this is one instrument where bone can be punched out. So again, it will bite backwards again, but it cuts the bone. So this is known as Kerrison punch. Okay, another, I mean, most commonly is known as Kerrison punch. Is also known as ronger. But most common use of this Kerrison punch is while doing endoscopic DCR. You will see the lacrimal bone. In order to punch the lacrimal bone, we use this Kerrison punch. Okay. And also, if you want sphenoid sinus ostium, you have seen, but you want to widen it, again you can use this sponge to take out the bone. But remember, most common use of this sponge is endoscopic DCR. Okay. Again, this is biopsy forceps. I'll just this will just grasp the tissue. This is not important. Just to complete, I have put it. That's all. Yeah. This is again. This every UG student should know this instrument. Although we don't use them now, but these are one of the most commonly used instruments before. Hence, we should know it. This is Tilly lid switch, antrum, Tilly lid switch, stroker, and cannula. So if you see carefully, this stroker is introduced into this cannula, and it looks like this. But there are two different entities. So you introduce this trocar through the cannula and this tip will come out. So tip will be of trocar, remember. So what is the most common surgery which we do? We do antral wash. What is this antral wash? When we did not have good amount of antibiotics, when we did not have endoscopes, for acute sinusitis not responding to medical or treatment or chronic sinusitis, we would do antral wash. What is this antral wash? Just around 2.5 centimeter behind the anterior end of the inferior turbinate, you use this trocar and cannula, okay, trocar and cannula in this manner, and direct this towards the zygoma or the pinna, and you enter the maxillary sinus. Why towards the zygoma or the pinna? If you direct this towards the orbit, you may end up injuring the orbit, right? So your direction should be towards the pinna. So you introduce it, take out the trocar, leave behind the cannula. Then you take 30 ml or 50 ml syringe, fill it with lukewarm water, and you flush the cannula. So what it does is, it flushes out the maxillary sinus through the natural ostium, all the pus will come out. So this is known as antral wash, right? So this we used to do it in OPD as an OPD procedure or office-based procedure. So this will be kept in your exam. 100% it will be kept. What is this? Tilly lid switch, trocar, and cannula. Okay. I hope I have at least you people have understood it. So most common indication to use this thing is antral wash. Where do you use it? Acute maxillary sinusitis not responding to medical line of treatment, chronic maxillary sinusitis. Other indication are, if you want to instill the drug into the maxillary sinus, you can use it. Or while repairing the oroantral fistula, you can use it. But most common, you have to tell acute maxillary sinusitis not responding to medical line of treatment. Okay, so these two instruments are also important. These will be kept. These two will be kept in your exam. So this is a Walshman forceps. This is a Walshman forceps. This we use to reduce the nasal bone fracture. This is Ash forceps. What is the difference between Ash and Walshman forceps? See this. Just a minute. See, this is for nasal bone, right? So the length of the blade is shorter. This is to reduce the nasal septal fracture. So septum is quite a lengthy structure, right? So look at the length of the blade, right? So if it is a long bladed instrument, it is a ash forceps. If it is a smaller bladed forceps, it is a Walshman forceps. Walshman forceps for nasal bone fracture, ash forceps for septal fracture. How to remember? A, yes, right? A for septum, ash for sep. In ash, after A there is S, right? So remember septum, S for septum. Remember like that. That is a better way of remembering. And remember the length of the blade. Okay. Now coming to tonsillectomy instruments. So next few instruments will be very, very important, and it will be what's the time? We have to finish it before 6:30, no, because there is a class, so we'll try to finish it. Okay, so tonsillectomy instruments are very, very important, so we'll just go through it. Okay, uses and all we have already discussed in tonsillectomy class, but still we'll discuss little. So what is this? This is boiled eyes, mouth gag, with blades, right? So this is Boyle Davis mouth gag. These are blades. Again, blades can be Davis tongue blades, or Russell, or Doty tongue blades. But most of the time we use Davis tongue blades only. There are two types of tongue blade. One, there will be a kind of opening or slit in the middle of the tongue blade, and few will not have opening in the middle of the tongue blade. What is this used for? See, if you have done oral intubation, generally we do the case under general anesthesia, right? But most of the time, which we do under general anesthesia, they would have passed the endotracheal tube through the nasal cavity and then into the trachea. So that is endonasal intubation. But some cases they will do oral intubation. There, this while doing oral intubation, this slit we use it to engage the endotracheal tube so that it is not compressed. Okay. Otherwise, if you use this blade, endotracheal tube will be compressed and there will be not enough oxygenation, right? So, while if there is oral intubation, we use this serrated or slit blade for to engage the endotracheal tube. That's all. Okay. Where all do we use it? Most commonly, adenoidectomy, tonsillectomy, right? Can we use in any other surgery? Of course, you can use it. Any oral surgeries or any soft palate surgery, we can use it. That is what any palatal surgery, nasopharynx, any surgery you can use it. Okay. If you want to do some surgery on the soft palate, you can do it. No problem. Okay. So after putting this Boyle Davis mouth gag with you have to fix them, right? So in order to fix them, you use Draffin's bipod, right? So you anchor this and you put it on the table so that your both hands are free to operate. So this is Draffin's bipod. Again, you use it for adenotonsillectomy or any procedures in the oral cavity, oropharynx, or in the nasopharynx. Okay. Yeah. So St. Clair Thompson, again another instrument. So please note down what all St. Clair Thompson we have discussed. Examiner will ask what are the St. Clair Thompson you know of. Okay. So there is a posterior endoscopy mirror, there is a thadicum, now there is a adenoid curette, right? Okay. See, there are two types of adenoid curette here. One is with cage. You can see that there are cages, right? Another is without cage. See, there is no cage here. So when do we use this and when do we use without cage? See, while adenoids will be midline structure, right? But that doesn't mean that adenoid should not extend near the eustachian tube opening, right? So while curating, you start with one with cage because it kind of lodges good amount of tissue and you take it out. You take out the big chunk of adenoids. But if you keep on curating with the same instrument, you may end up injuring the prevertebral muscle. And if you do it again, you may end up injuring the eustachian tube if you use it laterally. But after taking out the bulk of the adenoid tissue, you switch over to this Beckman adenoid curette without cage, where what we do is you can sweep out easily the part which is present in the lateral part. So there won't be injury to eustachian tube or the prevertebral muscles. So in order to avoid injuring these vital structure, we switch over to without cage one. That's all, right? Okay. So that is for adenoidectomy. Now you have put Dennis Brown this thing and you have put it in Draffin's bipod. Now to do tonsillectomy. For that you have to hold the tonsil, right? So first is you have to hold the tonsil. So how are you going to hold it? You hold with Dennis Brown tonsil holding forceps. Okay. This is relatively atraumatic. We also use it to hold the tongue, all those things, but most common is tonsil holding forceps. Okay. You hold the tonsil with this and pull it medially, or you just put a pressure. Then you will identify the anterior pillar. Then what instrument do we use? Just a minute. We use vas forceps, what teeth forceps to make a vas teeth forceps to make an incision anterior to anterior pillar on the mucosa, which is a J-shaped mucosal incision, right? Then so you hold the tonsil with the tonsil holding forceps, then put an incision with the vas teeth forceps, then you use this instrument. What is this? Guan-Evans tonsillar dissector. So what are we going to do? With the blunt end, see it has got a two ends. It has got a serrated end and another is blunt end. So with blunt end, you reach the peritonsillar area. Okay. Once you are sure that you are in the peritonsillar area, then you switch over to this end and you dissect the tonsil from the anterior pillar, posterior pillar till you reach the lower port. Right. So Guan-Evans tonsillar dissector is to dissect the tissue from the tonsil from its bed till the lower port. Where else can we use it? We also use it in convolute surgery. We also use it to curate some of the cannulations in case of Mastoid surgery, but very rarely we use it. But most common use is as a tonsillar dissector. Okay, there is one more dissector, that is Mollison's tonsillar dissector with pillar retractor. See what is the difference between this and this instrument? See, it has got a blunt end and serrated end, whereas this end it has got blunt end and the other end has got a retractor. Where do we use it? You would have done finishing tonsillectomy. Now you want to see where is the bleeding is from. So you pull the anterior pillar with this pillar retractor, see where the bleeding is from. Okay, so this is Mollison's, this is Guan-Evans. Okay, then you have dissected the tissue till the lower port. What else do you do? You are going to snare it. So this is, just a minute, sorry, yeah. This is Eve's tonsillar snare. If you see, there is a wire, right? So what is it made up of? It is made up of stainless steel. See these, whatever I have marked in red, they are important. It is 3-inch long. And what is that gauge of that? What is the thickness of that stainless steel? Which is 28 gauge, right? So remember this, it is made up of stainless steel, which is of 3-inch long and the gauge is 28 gauge. So you want to engage the lower pore and snare it. Why do we snare it? By snaring the lower pore, we are crushing and cutting the tissue. By crushing, it will release tissue thromboplastin and there will be early hemostasis. And also by crushing, the vessels which enter the tonsillar hole, most of the vessels enter the tonsil through the inferior pole, right? So I am crushing the vessels as well. So there will be mechanical crushing of the vessels as well as tissue thromboplastin will be released. That will activate the external coagulation pathway and there will be early hemostasis. Okay, so this is Eve's tonsillar snare. So you're going to put your thumb in this ring and the index and the middle finger in these two rings. Then you crush it. Okay. Okay, now you did tonsillectomy. Now there is a bleeder. So what are you going to do? If there is bleeder in the bed of the tonsil, you catch the bleeder with the first artery forceps. So if there is first artery, there has to be second artery forceps, right? So this is second artery forceps. So how to remember first artery and second artery? So first artery, it do not have any bend. So one also do not have any bend, right? Whereas second artery, it has got a bend. See. So first artery, no bend. Second artery, it has got a bend. And how to remember the name? Alphabetically, B comes first, then N comes. Okay. So although it looks silly, remember, you will get confused. You people will be telling Negus first artery and Burkitt second artery. It is not so. So alphabetically, B comes first, then N comes, right? So Burkitt's first artery forceps and Negus second artery forceps. Where do you use first artery? If you see any bleeder, you catch the bleeder with the first artery, right? But because of this straight thing, if you try to put a knot, it will not stay there because the amount of tissue we caught is less. We have caught only the bleeding point, not the tissue surrounding it. But you hold the first artery, you catch the bleeder with the first artery, then you change it over to second artery. Now the amount of tissue which is caught in this will be more, and because of this curvature, if you put knot, it will safely goes and sits there. Okay, so first artery is to catch the bleeder. I hope I am getting, you people are getting the point. First artery is to catch the bleeder. Second artery is to ligate the bleeder, right? First artery to catch, second artery is to ligate. So first artery is Burkitt's, second artery is Negus. I'm stressing it because it is that important. Okay. Okay. Now this I have already explained. Of course, blood and all, how are you going to suck it out? You use Yankur suction tube. Again, it is made up of stainless steel. Now even plastic made one comes, which is disposable. This we autoclave it. Okay. Again, all the instruments are autoclaved. Remember that. This also they will ask how to autoclave. I mean, how to sterilize the instrument. You just tell autoclave. Okay. So anchor suction tube, where all do we use it? We use it for tonsillectomy, adenoidectomy, any oral cavity surgeries or any oropharyngeal surgeries, we use it. Okay. And see the tip once. It has got a blunt end. So it is atraumatic suction. Okay. That's why you use it. Okay. This I have explained. Okay. Now, what is this lux? What is this name? Lux tongue depressor. We use, so where all do we use it? We use it to examine the oral cavity, oropharynx. Where else do we use it? To see for the tonsil, how long are the, I mean, what is the grade of enlargement? We will get to know by examining the tonsil. So how are you going to examine the tonsil? To use the tongue depressor, depress the tongue. Second one. And what is Irwin Moore saying? Take the tongue depressor, push the tongue depressor, push the anterior pillar with the tongue depressor. If cheesy material comes out of the tonsil, that means Irwin Moore sign is positive. That means patient has got chronic tonsillitis. So another use of Lux tongue depressor. Another important use is you do this something known as fog test, right? So what are you going to do? You put the tongue depressor near the nasal cavity, ask them to take breath normally. See for the fogging of tongue depressor on either side. If there is decreased fogging, that nasal cavity has got some obstructive pathology. Okay. Where else do we use it? You also use it for posterior rhinoscopy. You depress the tongue with tongue depressor, take the posterior rhinoscopy mirror, pass it into the oropharynx without touching any structure, and then you do posterior rhinoscopy. Okay. So these are some of the uses. We also use it while operating small surgeries in oral cavity, just to kind of retract the lip, all those things. So these are some of the examples which I told. Okay. Okay. Now quinsy forceps. So what is quinsy? Peritonsillar abscess is known as quinsy. What happens in quinsy? Abscess or pus is collected in the peritonsillar space and pushes the tonsil medially. So what is the treatment? You have to drain the pus. Where are you going to drain it? If there is any pus pointing, you do it. Or if there is no pus pointing, you draw two lines. One line along the base of the uvula, another line along the anterior end of the anterior what is that, pillar. So the point where these two lines meets, there you can drain it. How are you going to drain it? You use this instrument known as St. Clair Thompson quinsy forceps. Again, another St. Clair Thompson now, right? So add to your list. So St. Clair Thompson quinsy forceps. So if you see carefully, it is kind of a diamond end. It looks like a diamond end. So it has got a sharp tip and it kind of pans out. Okay, it kind of pans out. Why this is present? If you poke little deep, you may go into the peritonsillar space, and there are important structures like carotid artery just lateral to the tonsil, right? So you should not injure major vessels there. So this will aid in stopping exactly in the peritonsillar space. You while poking, you close the end, you close the tip, you poke it, then you open it, then pus will drain out. Okay, so this is known as quinsy forceps. The complete name is St. Clair Thompson quinsy forceps. Okay, please remember. Please list out all St. Clair Thompson I have told so far, and also list out all Freers which you know of. Freers area, Freers elevator, all those things. Okay, and Freers line, all those things. Okay, this is indirect laryngoscopy mirror, which I have already spoke. So what is the difference between posterior rhinoscopy and indirect laryngoscopy mirror? The handle is straight in indirect laryngoscopy, bayonet shape in case of posterior rhinoscopy. Okay, so just to finish up the topic, 2 or 3 more instrument, I guess, then we'll wind up because there is a class later, right? So there are two scopes which actually there are three scopes which every ENT student should know. You may not use it, but you should know. One is bronchoscope, not this. Another is esophagoscope. Another is direct laryngoscope. Okay. So what is this bronchoscope? Where do we use it? Bronchoscope, we use it for diagnostic as well as therapeutic purpose. What are the diagnostic purpose? If child comes with unilateral pneumonia, for example, right-sided pneumonia which is not responding with IV antibiotics, pediatrician will suspect foreign body. So you're going to put the bronchoscope, see if there is any foreign body, you can take it out. So this becomes both diagnostic as well as therapeutic indication, right? Just like that, there are so many diagnostic and therapeutic indication. Most common diagnostic indication is if there is any blood stains sputum to examine the tracheobronchial tree to see for any growth ulcers, to take biopsy from any suspected growth, to give to get bronchial lavage. Okay, for all these things we use it. But for treatment purpose, you must tell foreign body retrieval. Please remember foreign body retrieval. And then if there is any growth in the bronchus which is obstructing the airway, we can just stent it. Okay, if there is any aspiration, we can just suck it out. And if there is a tumor, there is endobronchial operations. Now they do it. Okay. So these are therapeutic indications. Now coming to this instrument proper, see it has got vents. There are small openings, right? Why these vents are required? Through this adapter, oxygen will be supplied and it comes through this bronchoscope and it will aerate the tracheobronchial tree and patient will not have any problem. So these vents are there for aeration of the lungs. Okay. And there is a small another opening, right? This is for suction purpose. If there is any discharge, blood or anything, you can suck it out. Through this vent, you can suck it out. And this is for light source purpose. Through here, you're going to see what is there in the bronchus. Is there any foreign body, tumor or blood, whatever it is. So through this opening, you can see this is actually endoscope what they have introduced. Even if it is not there, you can see here from here, right? And this is the light delivery. So this is a light delivery instrument. So they are delivering the light. You can easily see light coming out. So there are two vents, right? And there is a oxygen delivery system, one for visualization purpose, one for suction, and one for light delivery purpose. Okay. And what about esophagoscope? I'll just finish this, then we'll come. There are no vents here, right? There are no vents. So this will be one of the most commonly asked questions for you. Can bronchoscopy used for esophagoscopy? If there are no esophagoscopes available for you, you can definitely use it because it looks similar, right? There is a pipe. Through this you can see this is for suction, this is for light source, right? You can definitely do bronchoscopy for esophagoscopy using bronchoscope. Whereas as there are no vents here, there are no opening for aerating the lower airway, right? You cannot use esophagoscope for bronchoscopy. Please remember this. So bronchoscope can be used for esophagoscopy, but esophagoscopes cannot be used for bronchoscopy. Okay. Where all do we use it? We do it to retrieve foreign body in the esophagus. Remember that you have to tell foreign body esophagus. Then if there is any dysphagia, we use it for a diagnostic purpose to see what is the cause for dysphagia. Okay. So if there is a structure dilatation can be done with along with Bucci dilatation. There are so many indications. I think you can read it. Remember one thing, there are vents in the bronchoscopes. Remember, there are vents in the bronchoscopes, but there are no vents in the esophagoscopes. Remember this point. This is very, very important. Okay. Now we also use flexible bronchoscopy. We don't have to anesthetize the patient. You can use it in a awake patient. You pass this into the nasal cavity and then into oropharynx and then into larynx and bronchus. Okay. You can do diagnostic purpose, not for therapeutic purpose. For therapeutic purpose, rigid are always best. Okay. Okay, this is direct laryngoscopy. We'll finish off faster. It has got handle, remember. Okay, and handle should be held in left hand. Okay, I will tell practical points in this. Handle should be held in left hand, and this should be introduced into the oral cavity, and right hand should be used for suction purpose or taking biopsy. So handle should be held in left hand. Remember that. If you are a right-handed person, if you are a left-handed person, you can hold with right hand. Remember. Okay. Okay. Where are to be use this direct laryngoscope? Yeah, this is important. It is made up of German silver. Remember, it is made up of German silver. Okay, again, to see is there any foreign body in the larynx, we can use it. To see any malignancy, proliferative growth, and you can take biopsy also. And if there is any growth, to see extent of the disease, where all it is extended. Is it restricted only to AE fold, or has it gone to the other areas? You can get to know by doing direct laryngoscopy. Okay. So remember, hold the direct laryngoscope in left hand. Okay, what are the contraindication to do direct laryngoscopy or any scopies for that matter? Aortic aneurysm, trismus, severe cervical spondylosis. These are some of the indications. Okay, aortic aneurysm, severe trismus, because you can't even introduce into oral cavity. How are you going to introduce it to larynx, right? And cervical spondylosis. These are some of the contraindications. Yeah, just I'll finish tracheostomy tubes and we will done. So if the patient comes to you with stridor in case of malignancy or any other pathology, you are going to do tracheostomy, right? When you do tracheostomy, you're going to use this type of tracheostomy tube, which is a cuffed portex tracheostomy tube. Why cuff? There is a balloon in the lower end. So if you inflate it, this will fill with air. So this is cuffed portex tracheostomy tube. Why do we use it? This cuff will prevent aspiration, because whatever the circulation will come and collect here, somebody can easily suction it out, right? So this cuff will prevent aspiration. This is used in case of emergency purposes. So when the patient is in ICU, when there is no cough reflex, you have to use this portex cuffed tracheostomy tube. Okay, and then you switch over to these type of tubes: Jackson tracheostomy tube and Fuller bivalve tracheostomy tube. Now patient is completely fine. You are trying to take out the tracheostomy tube, but you are not sure if he is going to survive the decannulation of tracheostomy tube. Then what we do? We change over to metallic tracheostomy tube. When do we change over to metallic tracheostomy tube? When patient can maintain lower airway, when he can cough, when he has aspiration free swallowing, then you can change over to metallic tracheostomy tube. Again, these are all made up of German silvers. Okay, what is the advantage of this metallic tube? Why can't we just use those before tubes? The advantage is that there is an opening in the upper part of the tracheostomy tubes here, metallic tracheostomy tubes, right? So what you can do is, this will be introduced into the tracheostomy tube, and patient can close this end, and air will come and blast through, and it goes into larynx and then oral cavity. So patient can talk with metallic tracheostomy tube, whereas this tracheostomy tube he will not be able to talk, because the air will go through this and comes out through the tracheostoma, right? There is no opening here, so patient cannot talk with portex cuffed tracheostomy tube, but his airway will be protected. Whereas metallic tracheostomy tubes like this Jackson and Fuller's, airway will not be protected, so patient has to be awake. He should not have aspiration symptoms, or he should have very good cough reflex. Then you can use this, close this end, and can talk. And to clean, you can take this inner tube just like this, clean it and put it back. He himself can clean it. That is the advantage of metallic tubes. But this, there has to be doctor to clean the tracheostomy tubes. Okay, he cannot clean himself. So these are tracheostomy tubes. And this is one of the entrance question they have asked. That is the reason why I have added this. This is voice prosthesis. Okay, this is tracheoesophageal voice prosthesis. When we do laryngectomy in case of malignancy larynx, we take out the voice box, right? But he has to have voice for the communication purpose, right? What we do is we make an opening in the posterior wall of the trachea and make a communication between the esophagus and trachea. So through that communication, so now there is a fistula between the trachea and the esophagus, right? So there is tracheoesophageal fistula, which is made by us. Through that fistula we can place this voice prosthesis, and it will be a valve processes. What happens is air escapes through this and air comes into the esophagus, and voice can be produced, but whatever the liquid in the esophagus will not come through this and into the trachea. So it is a valved processes. Okay, so this is an image based question. Remember, it is a voice prosthesis, more so bloom singer voice process. There is duck bill, indwelling, non indwelling and all, you people don't need it. Remember, this is a voice prosthesis which is bloom singer. Okay, so if there is any doubt, you people can ask. This is the end of the instruments. Okay.
Sir, there are a few doubts in the chat section, sir.
Yeah, definitely.
Yes. So, are the doubts visible, sir?
Yeah, I can hear, but I can't see any doubts, man. Charts, no? Yeah.
Yes, sir. If you stop the screen sharing, then
yeah. Okay, great. How to correctly hold the otoscope? Okay, yeah, that's a good question. So what you should do is first, with the left hand, you pull the pinna posterior superiorly, then hold the otoscope handle with the right hand, then you put the otoscope slowly into the ear. So always pull the pinna in the posterior superior direction, straighten the external aortic canal, then you put it while examining the right ear. Left ear, some of the examiner says it has to be ulta. Pull the pinna with the left hand and then put it. But few examiners say it doesn't matter. You can use same hands for both the ears. It is up to examiner choice. Okay. To limit the extension inside. No, it is nothing like that. Remember, just pull the pinna in the posterior superior direction. Hold the handle of the otoscope, not the head of the otoscope. Then you slowly introduce it. Okay. What does teasing mean? Or teasing mean? Okay. See, the thing is, temporal asphyxia we would have harvested, right? But the thickness may not be as thin as tympanic membrane. So what we do is we just take out or one of the there will be few tissue which is adherent to the temporal asphyxia. So we try to take it out. We try to thin it. That is known as teasing. Does aeration obstruct the weave in rigid bronchoscope? No. See, the thing is that itself is a different topic. There is something known as jet ventilation. There is something known as intermittent ventilation. There are too many things. Okay, so it will not obstruct. So that will not a thing. But if you are doing intermittent aeration, then a surgeon has to operate. Once the SpO2 comes down, again he has to retrieve. He has to connect the port. Again, he will oxygenate. He will stop procedure. It is like that. Okay. Sir, in cegal speculum, we can administer medications in middle ear. So, a tympanic perforation is necessary for it. If you want to administer medication into the middle ear, it would be already, see, if the tympanic membrane is normal, why will he come to us for cecalization and all, right? So there has to be CSOM or some other pathology, then only we'll need medication. Or, for example, if there is no infection, if the tympanic membrane is absolutely normal, there are some pathology like Meniere's. There you may need medications to enter into middle ear. There we would have put the small, what is that, Grommet tube. Then again you can use seagulls to introduce the medications into the middle ear. Okay, I hope that completes the doubt. So tympanic membrane perforation is necessary. It may be previously existed perforation, or you have created of your own and you would have put the grommet tubes there. Okay. So remember, bronchoscopes can be used for esophagoscopy. Esophagoscope cannot be used for bronchoscopy. Remember that. One more message. Thank you. Okay.
It was an interesting session, sir. Thank you so much, Dr. Puneeth, sir, for providing insight to the instruments used in ENT. We could learn a lot because of this wonderful session, sir. Thank you so much.
Yeah, no problem. Thanks a lot. Study well, all the very best, and keep safe.
Thank you, sir. I thank all the participants for their active participation. Thank you, one and all.